Additional right now.
Ma'am, you are
No,
on
what?
mute. Please unmute yourself.
We are live now.
Yeah.
Okay.
Yeah, not officially and formally.
Yeah, but ठीक है. For us, you're additional. Worry not.
Sir, we are live on YouTube.
Okay.
Sorry, sir. You have to unmute yourself.
Yeah. Good evening, everyone. Welcome to the 8th session of Anterior segment surfing, and we come back once again with strabismus. We had done one session earlier, which was I think on Duane retraction syndrome, and not too far from that, we are still looking at our limitation in abductions. We are now having another session this time on the Abducens palsy, and it's my pleasure to have on board with us some very esteemed panel and speakers who are experts in the field of pediatric ophthalmology and strabismus and neuro-ophthalmology, both of which are very important for what we have to discuss today. Our guest speaker today is Dr. Swati Fulgele, who is an additional professor at Dr. R.P. Center for Ophthalmic Sciences, AIIMS, New Delhi. Welcome, ma'am. The case that will be presented by Dr. Ashwini Behra, who is also from RP Center, AIIMS, New Delhi. Currently, he is a consultant at ECOS Hospital in Behrampur, Odisha. On the panel, I'm very happy to have with me a senior of mine, Dr. Paromita Datta, who is an assistant professor at the Guru Nanak Eye Center in New Delhi, Maulana Azad Medical College, New Delhi. And we have Dr. Subhajit Bhattacharjee, who is from Sitapur Eye Hospital, and he's a consultant in pediatric ophthalmology, strabismus, and neuro-ophthalmology at the Sitapur Eye Hospital. I'm Dr. Digvijay Singh, and I'm going to be moderating the session. I'm the president of YOSI, and again, I have a special interest in pediatric ophthalmology, strabismus, and neuro-ophthalmology. So welcome to the speakers and the panelists, and welcome to all of you who are here now hearing this session. So to begin with, I would like to invite Dr. Swati Fulgele to tell us all about the Abducens palsy in her talk, and we'll follow that up with a case by Dr. Ashwini Behra, and who's going to also show us a very nice surgical video in that. So Dr. Swati, I'm all yours.
Yeah, thank you, Digvijay, and thank you for promoting me. And thank you for having me, and thanks to Yosi for inviting me for this guest talk. I would be, sorry. Is my screen visible now? No, not yet.
Not yet.
Is it visible now?
Yes, ma'am, it is.
Yeah, okay.
Not in presentation mode yet, but yeah, now it is.
Yeah. Thank you, Yosi, for inviting me for this talk, and I would be talking basically about Abducens nerve palsy. I would like to cover both neurophthal as well as strabismus aspect of the sixth nerve palsy. Let's see how much I can do within the span of 10 minutes. So to begin with, sixth nerve palsy, as we all know, it present with the clinical features of head posture, where the head would be turned on the side of the paralytic nerve. And the most striking feature would be, of course, esotropia in the primary gaze and limitation of abduction on the side of paralysis. The most common differential and the most common mistake what residents as well as general ophthalmologists make when we are dealing with the cases of sixth nerve palsy is to confuse it with the type 1 DRS or ESO DRS, where you also have limitation of abduction, but at the same time there will be retraction on adduction and increase in palpebral aperture on abduction. So whenever you are having this kind of case, please make note of the fact of retraction, upshoots, downshoot to differentiate it from DRS. Also, even if there is no retractions or upshoot in the primary position, you can note the amount of deviation. So in a case of sixth nerve palsy, the amount of deviation is much, much more as compared to DRS. The next common differential is a case of an infantile esotropia with cross fixation, where if only versions are checked, you may have this kind of picture as you can see in this figure down here, where you have kind of limitation of abduction in each eye on in either gazes. So it's important to look for adductions also. So cover each eye with and then look for the abduction, where you will find that the eye is now moving fully. So these are the two most common differentials that are confused with the sixth nerve palsy, and one should be careful about these two diagnoses before making a diagnosis of sixth nerve palsy. So once you are clear, and patient would always complain of diplopia if it's acquired sixth nerve palsy, not seen in congenital sixth nerve palsy because of suppression, but in acquired sixth nerve palsy, diplopia is common, and it's an uncrossed diplopia with the maximum suppression on the ipsilateral side. Then, as in hair charting, you can see that the eye which is involved has a smaller chart, as well as there will be limitation of lateral rectus, which is quite visible in this eye on the right side. On the other hand, the antagonist muscle will show the overaction, and the left eye, all the muscles, especially the medial rectus, will show overaction. Now, coming to the causes of sixth nerve palsy, it can range from vascular occlusion, ischemia, to hemorrhage, neoplasm, other mass lesions, inflammation, as well as metabolic disorders. So, the presentation of the sixth nerve palsy it determines or gives a kind of differential to investigate the case. And how we proceed is what I would like to cover in this talk, as well as how we manage surgically these cases. So it may present as an isolated mononeuropathy, ischemic mononeuropathy in an old patient, where you have a history of risk factors like diabetes, hypertension, and dyslipidemia or CVAs and other risk factors. So if it is seen an old patient with the known risk factors, it's probably ischemic mononeuropathy, and you may probably not investigate it any further unless there is any sign of worsening or there is any other sign of associated neurological lesion. But if it is there in young case, as in this case where you have a 27-year-old female presenting with inability to move left eye for almost 10 days associated with headache and fever, in such cases, it is very, very important to do neuroimaging, as we did in this case, and we found out that there was a lesion, most probably a fungal inflammatory lesion at the level of cavernous sinus. I'm sure you can see here, which was enhancing homogeneously on the contrast MRI. So MRI is an investigation of choice when you want to do a neuroimaging in cases of any neuro-ophthalmological disorders, particularly cranial nerve palsies and optic nerve associated disorders. Sixth nerve being the nerve which is embedded in the substance of cavernous sinus is the first nerve to get involved. And whenever you have such kind of history of headache with and fever with mild proptosis and limitation of abduction, probably the first differential that should come in mind is a cavernous sinus involvement. Sometimes the sixth nerve may present without any, what I mean, sixth nerve may not have a localizing sign. It may have a false localizing sign, especially in cases of raised ICT, where it gets compressed against the petrous ligament. And it's important to look for fundus. So it's important to look for fundus in such cases so that you don't miss on a case of raised ICT. Then this was another interesting case where you had a 30-year-old male who presented with inability to move eyes towards right. Now, if you look at this case very carefully, in the right gaze, the eyes are not moving it at all, and in primary gaze, the eyes are slightly towards left side. In the left gaze, you can see that the left eye is moving, abducting completely. So is the right eye, which is adducting completely. While in right gaze, there is no adduction as well as no abduction. So this is not a simple case of just a sixth nerve palsy. This is a case of right gaze palsy along with the right sixth nerve palsy. Now, if we do doll's eye movement in such a case, as in this particular picture, you can see that the adduction is complete, but the abduction is still incomplete. So that's how you can differentiate a supranuclear versus from a nuclear as well as infranuclear palsy. So in supranuclear palsies, the dorsal movement show complete range of ocular movements. But in infranuclear and nuclear nerve palsies, there will be limitation of movements even with dorsal movements. So in this case, when we did imaging, this is what we found a small inflammatory lesion at the pons, which is the level where the nucleus of sixth as well as seventh nerve is located, as well as the PPRF, which is a gaze center for horizontal gaze, is located. So please look carefully for all these gaze palsies also when we are dealing with the sixth nerve palsy. So a nuclear sixth nerve palsy usually presents with horizontal gaze palsy. Peripheral seventh nerve dysfunction also is seen, and most probably the lesion is localized at the level of pons. At the same time, you may have sixth nerve involvement, seventh nerve involvement, eighth nerve involvement, and papilledema, which is a sign which can be localized at the level of CP angle tumors or at the dura of clivus. So various tumors can also cause sixth nerve palsy, especially if they are at the level of CP angle. So the role of neuroimaging in these cases are very, very important, and this is how we should proceed. So if we have a case of sixth nerve palsy, now first we have to look at it whether it's an isolated sixth nerve palsy or there are other cranial nerve involvement as well. So if it's an isolated sixth nerve palsy, look at the age, whether the age is less than 60 years or for that matter 50 years, or it's more than 50 to 60 years. Again, if there is a presence of risk factors like diabetes, hypertension, or vasculitis or dyslipidemia, we will not proceed to imaging instantly. In fact, we can wait for another 4 to 6 weeks where you have to say whether the improvement is occurring or not. Even in this meantime, if there is signs of other neurological involvement, then you should proceed to imaging as soon as possible. If there is no improvement even after 8 weeks, then one should definitely do imaging to look for causes, because most of the time the isolated ischemic mononeuropathies do improve on their own without any intervention, and generally within a month or so. So on the other hand, if you have involvement of multiple cranial nerve palsies, one may instantly do imaging. So this is how we proceed to evaluate a case of sixth nerve palsy. And what are the indications of therapy? So indication is number one, diplopia, especially in acquired cases where the patient is unable to perform his daily activities, and constant anomalous head posture when present can cause not only cosmetic problem but a constant strain in neck. And to avoid all this, we have to treat the patient. Now treatment can be temporary till the recovery occurs, or it can be permanent in form of surgical treatment when there is no recovery or partial recovery. So the non-surgical management includes giving prisms if the deviation is small, between 10 to 15 prism diopters. It can also include segmental occluding devices because they are more cosmetically acceptable, but they are not very radially available, not at least in Delhi. And one can also use occlusion, though it may have a cosmetic problem, but it is the most effective one to eliminate diplopia, and also to treat amblyopia if it's occurring in children less than 7 to 8 years of age. So till the recovery is done, one can use the non-surgical management. The other option of doing non-surgical management is to use botulinum toxin with the dose of 2.5 international unit, which can be injected into antagonist muscle, which is the medial rectus. It prevents the contracture of the medial rectus. It also reduces the size of deviation temporarily, and also causes symptomatic relief in form of decreased diplopia. So there are studies which say that this is effective, and sometimes much more. It can be combined with the surgical procedure also when we do transplantation. So it can be used along with the surgical procedure also. So this is just to show a case of Botox injection, where you can see that this was a case of post-traumatic sixth nerve palsy, and we injected Botox, and temporarily there was improve in abduction, which lasts for almost 3 months or so. And if in meantime, if there is a complete recovery, you need not repeat the injection. But if there is no recovery or partial recovery, a repeat injection may be given. Then when to do surgery? So it's important to wait for at least 6 months before the stable deviation is achieved, and you are sure that whatever you are dealing with is not, whatever deviation you are dealing with is not going to change. The aim is to achieve the binocular single vision in the primary gaze and to eliminate diplopia in the primary gaze is the main aim. So there are various surgical options, and this is the algorithm for how to proceed, for how to choose one particular option over the other. So if there is a complete recovery of abduction, for that matter, even if there is a partial recovery of abduction, one can choose to do a resection procedure on the same eye. But if there is a limitation of abduction, then you have to see whether the FDT is free or not. If the FDT is free, that means that the power or the innervation in the lateral rectus is almost negligible, and one may proceed directly with the transposition surgery. If the FDT is tight, then you're not sure whether this limitation of abduction is because of the tightness of the medial rectus or because of the poor innervation of the lateral rectus. So in that case, after doing FDT, it's important that we do active force generation test also, or AFGT. If the AFGT is weak, then you know probably that this lateral rectus is not going to generate any force and your resection would fail. In that case, you can combine MR recession with transposition surgeries. If there is some kind of moderate force in the lateral rectus, again one can proceed ahead with doing a recession and a resection procedure. So as in this particular case, this was a case of post-orbitotomy lateral rectus palsy in the left eye. And you can see that the left eye recovery is, abduction recovery is pretty good. So one can proceed ahead and do a resection procedure in such cases. But you have to keep in mind that the normal nomograms for resection and resection may not work in a paralytic squint, whether it's a 6th nerve or a 3rd nerve. So you have to probably do a supramaximal recession and resection procedures in such cases. So we did a 9 mm of recession of medial rectus and 12 mm of resection of lateral rectus in left eye to achieve almost an ortho position in the primary gaze and the good abduction in the left gaze. Now, if you do not have a full recovery of abduction in this, then you have the option of doing transposition surgeries. So transposition surgeries, you have to transpose the vertical recti, which is the superior and inferior recti, towards the lateral recti. So some kind of, abduction force is generated. So it can be a double muscle transposition surgery, which again can be a full tendon transposition or a partial tendon transposition. It can be a single muscle transposition nowadays, which is gaining popularity day by day, which can be a superior rectus transposition or an inferior rectus transposition instead of transposing both vertical recti. All these procedures can again be augmented with the MR recession, which can be put on the adjustable sutures to achieve more predictable outcome, as well as use of posterior augmentation sutures can be done to improve the abduction in these cases. So I would just take you through the cases where we have done various kinds of surgeries and the results what we have achieved. So this was a case of traumatic 6th nerve palsy, and you can see that the abduction was deficit on the right side. There was no abduction at all. So, and the FDT for medial rectus was negative. So doing a medial rectus recession itself may not work in this case because the FDT is negative. So we went ahead and did a full tendon transposition for this patient. So post-op, this is a 1 month post-op picture. So the results in primary gaze is almost ortho, as well as we were able to achieve some amount of abduction in the right gaze, which was, even though not complete, but was good enough to eliminate diplopia both in primary as well as in right gaze. The next case again is the case of post-traumatic sixth nerve palsy, but unfortunately in this case there was a serious abduction deficit, and there was also an very tight FDT for medial rectus. So one thing is sure that when you have a tight FDT for any muscle, you have to recess it so that you can release the FDT and make it free. At the same time, because there was a severe abduction deficit and fourth generation test was poor, we had to do transposition surgeries. So in such cases, when you are operating a 3 vertical recti, the chances of anterior segment ischemia is very, very high. So in such cases, hemorrhaging procedure where we transpose only the lateral half of both the vertical recti towards the lateral rectus can be done along with the medial rectus transposition. The risk of anterior segment ischemia, though less, is not completely eliminated. So this is a 6 weeks post-op for the same patient where we did medial rectus recession, a supramaximal recession of 9 mm, along with half muscle width of vertical recti transposition towards towards LR. So some kind of, there was ortho in primary position and some kind of abduction was also achieved. Now this surgery can also be modified with the posterior augmented suture, which is also known as Foster modification. So after doing a transposition surgery, 8 mm from the original insertion, we put a suture at the muscle and fix it to the sclera as close as possible to the lateral rectus, so that the augmentation of the force generated during the abduction is increased. This can also be combined with medial rectus recession, which may or may not be put on the adjustable suture depending on the need. The another procedure that is described but not very popular is the Jensen procedure, where you tie the belly of the lateral rectus to the superior rectus as well as inferior rectus. And it is also a kind of transposition procedure, but the only problem is that since the lateral rectus is anyway paralyzed, tying the belly of superior rectus and inferior rectus to the each half of lateral rectus may not work as well as the full tendon transposition. Also, if you tie the ciliary artery along with it, then the risk of anterior segment ischemia is still there, even though it may be less than the full tendon transposition where you transpose the entire width of the muscle belly. The another procedure that is gaining popularity or is being done now often is Nishida's procedure or the modified Nishida's procedure. In Nishida's procedure, what we do, we generally split the vertical recti into two halves, but we do not disinsert it. So the lateral half of the vertical recti without being disinserted is placed closer to the lateral rectus and sutured there. So the force is now transmitted laterally also, but at the same time, because one is not disinserting the muscle completely, there the chances of anterior segment ischemia is very, very less. It has a modified version where instead of splitting the muscle entirely into half, you just take the bite from the lateral half of the vertical recti and then fix it to the sclera as close as possible to the lateral rectus, around 8 mm posterior to the insertion of lateral rectus. So this procedure has been done lately, and again it can be combined with the adjustable medial rectus to gain more predictable outcomes. The one procedure which probably is being done almost and has probably replaced the VRT nowadays is the superior rectus transposition procedure with adjustable medial rectus recession. So here, instead of transposing both the recti, just the superior rectus muscle is completely disinserted and transferred as a full width. So the advantage is that we save on the circulation of at least one vertical rectus muscle, which is the inferior rectus muscle. This again can be combined with the medial rectus recession if the FDT is tight, and or it can be done as a standalone procedure if the FDT is negative. So this was one case where we tried doing SRT with adjustable medial recession, and this procedure is also known to is also shown to have good improvement in abduction, as you can see in this particular case, where the eye in the primary position has achieved ortho position, as well as there was an improvement in abduction. So this was a latest review article published in IGO 2019, where the different procedures for the different transposition procedures for the lateral rectus palsy were compared, and the conclusion was that the single VRT with or without augmentation, along with the medial rectus recession, probably works as good as full tendon VRT, or sometimes maybe better than full tendon VRT. For improvement, for achieving the good primary good outcome in the primary position, as well as improvement in abduction. So to conclude, I would like to say that you have to tailor your surgical procedure according to the condition, depending whether the abduction has been recovered fully or not, or whether the FDT is tight or not. Also, before you proceed for surgery, please evaluate the case completely and try to localize the lesion. And surgery should not be hurried, because sometimes, especially the isolated ischemic mononeuropathies, do recover on their own. Thank you.
Thank you, ma'am. That was indeed a wonderful presentation and did justice to the topic of all about abducens. You've covered everything that there is to know about the abducens palsy in this short period. So I think for all of us, as residents and fellows, we must know the neuroanatomy very well for the abducens palsy as well. And in fact, for all the cranial nerves that are there, with pertaining to the eye. So we know that as it's coming from the from the pons, actually on the dorsal part of the pons at the level of the fourth ventricle, and then it moves up slightly anteriorly and then exits at the pontomedullary junction, and it's just where the nucleus is of the seventh nerve as well. And then from there it's going on to the base of the skull over the pterygoid apex, and then entering the cavernous sinus. This is the only nerve which is within the sinus, as against the other nerves like the third, fourth, fifth, which are outside on the lateral wall. And then it is entering the orbit through the superior orbital fissure. So based on wherever based on where the lesion is, you may have slightly different presentations. But the long and short of it is that since it is only a purely motor nerve, a purely efferent nerve, everything is going to end up with the lateral rectus showing some kind of an underaction. And of course, because it is only giving an input to one muscle, that's why there are so many surgical procedures available, because the other extraocular muscles are available for movement, for transposition, and all of this sounds very complicated, though it's probably been years and years of these procedures coming out, and all of us learning as it has been, more and more innovations have happened. But at the end of the day, I think there are a lot of options for abducens palsy. So we are, as ophthalmologists or as squint surgeons, we're not very scared when we come across a sixth nerve palsy which needs a procedure to be done.
Vis-a-vis a third nerve palsy, which probably is most difficult to treat. Exactly.
But that doesn't really leave us with too many other thoughts. Any thoughts from Dr. Paramita, Dr. Subhajit before we move on to Ashwini?
Yeah, hello, sir. Yeah, ma'am has covered everything pretty much. So I think I just wanted to just focus on the timing of the surgery. That is something I felt we could just add on something. When do we actually operate? Is it do we wait for a while, for 6 months, as we normally do, or do we hurry it up? So the literature, I've gone through the literature. It says there was an article which was we just mentioned if it doesn't work, if we just see the saccage, and if the saccage are not at all improving by maybe 3 months, then even after 3 months we can go ahead with the surgery for the complete LR palsy. The important part is we have to go ahead with the surgery before the contracture actually starts developing. Because once the contracture starts developing of the medial rectus, contracture starts developing, then pretty much the results become very unpredictable. So that's something we can think ahead.
Yeah,
Anything
so
else?
I
Yeah,
think
ma'am.
what we normally used to follow was that if on so typically we could comfortably wait till 6 months earlier on, but now we've seen that if in two follow-up visits, I personally don't find any improvement happening.
Yeah.
Which the visit should be at least about 4 to 6 weeks apart. That's when I start thinking in terms of surgery. What about you, Dr. Swati? What is your thought?
Yeah, I think that also depends on the etiology, because ischemic mononeuropathies, even if you wait for say some more times, which generally improves within 8 weeks to 3 months. So those are the cases where you can wait. Vis-a-vis a traumatic, which generally, if you know, probably will not recover, and you want to hurry up into surgery.
And there is the option of using Botox for the medial rectus always if the patient is
Yes.
very much discomforted with diplopia and cannot maintain his head posture.
Right. Indeed. And so what we will do is Dr. Swati, if you could stay on for a short while, we'll have Dr. Ashwini present a case. Maybe we can get some expert comments on that as well. It's a very short case. And I would request if you can, of course, Ashwini, the stage is over to you. And, let's hear about your interesting case and, how you managed it.
Am I screen visible?
Yes.
Yes.
It was a nice talk, ma'am. You almost covered everything. I will present one of the case. Myself, Dr. Ashwini. I am a consultant at Ecos Hospital of Barampur, Odisha right now. There is no financial interest, and whatever little I know in this world of ophthalmology, credit goes to this beautiful RP center. 46-year-old male with a patient has complained of inward deviation of right eye and diplopia for the past 9 months and inability to abduct the right eye. And there is a history of RTA preceding the onset of illness. There was no significant past history. On systemic examination, on such cases are necessary, as we know, a patient presented after already 6 or 8, 9 months old. So there is no such systemic history there, but we must need to take such history, because in RTA patient have multiple injuries, patient was admitted for ICU, so it need to take on the systemic examination. Now coming to the ocular examination, I will focus on some important parts. Vision is 6/6 PR accurate in both eyes. On head posture, patient had right face turn around 30 degree. This was on examination. On Horsbach test, where we project a light over the patient's forehead and we see the pupillary reflex. And it depends on where the pupillary reflex found, whether on the pupillary margin or in between the pupillary margin and the limbus or at the limbus. It decides on that. So there is esotropy of approximately 20 to 25 degree. And on cover test, there is right convergent squint. On when coming to the ocular movement, there was on dextroversion, there was no there is limitation of movement. I am repeatedly telling, I will be telling only the word limitation is much more important. There is, we mostly sometimes use the word restriction, but the limitation of word will be the appropriate word. Now coming to other examination within normal limit. Vitreous, fundus, and everything is within the normal limit. Now coming to the preoperative examination. When you get a 9-gauge CP of a patient, don't need to start from the left top corner or right top corner. We have to start depending on the gauges: primary gauge, secondary gauge, and tertiary gauge. When you look at the primary gauge, we can see there is esotropia in the right eye. Now after that, we move to the secondary gauges like dextroversion, levoversion, shorsham and deorsam. On dextroversion, as we can see, the left eye, there is almost 1/3 of the cornea is inside the medial canthus, which means in this dextroversion, there is no movement. There is limitation of movement on the right eye. I am repeatedly again telling there is limitation of movement of the right eye. Restriction word can only be objectified when we do FDT. So there is proper word is limitation. But on levo version, we can see, how can we say this is a levo version? The right eye on levo version, almost it is on the lateral canthus, is touching the lateral part of the limbus. So we can see a little movement of the medial rectus on the part of the right eye. On Swarsham version and Obgaze, we see the lower part of the limbus is almost on the same position. On the Duersham version, we can see upper part of the limbus on the same position. So there is no limitation of movement. The only limitation of movement is on the dextro version in the of the right eye. On the coming to the tertiary gauges, on the dextro elevation and levo elevation, dextro elevation to check for the inferior oblique action of the left eye, and levo elevation to check for the inferior oblique action of the right eye. We see there is no as such overaction of the as such. Similarly, for superior oblique, we can see on the dextro depression and levo depression. Now, after that examination, after you did a proper 9-gauge examination, we need to come to the primary deviation and secondary deviation, which is most important. What is primary deviation? In primary deviation, we measure the deviation with normal eye fixing. So in this case, with left eye fixing, we'll measure the deviation of the right eye, which is the abnormal eye, which is a paralytic eye. So we must remember, it does not make difference whether we put prism bar on which eye. People almost or sometimes get confused which eye to put prism. It's not the which eye you put prism, it's the eye which we are going to fix. In primary deviation, the normal eye is getting fixed. On secondary deviation, the abnormal eye, that is the paralytic eye, is going to be get fixed. So when come to primary deviation, it's always known in paralytic cases, secondary deviation is always more than the primary deviation. In primary deviation, in such cases with left eye fixing and primary gaze is on approximately 45-degree base out prism. On dextro version, as we know, the measurement is going to be more. But when come to secondary deviation with paralytic eye fixing, the primary gaze cannot be assessed because patient will not be able to move. Patient will not able to bring his eye to the primary position. Now coming to the diplopia charting, this is the reason why patients have a same side face turn, because to avoid diplopia. On primary gaze, patient have a diplopia. On dextro version, the image of the right side eye will go further away. On levo version, the image will be come closer and there will be less diplopia or no diplopia. This is a haze charting. On haze charting, we'll see there will be more response on the left eye because of the smaller eye, the right eye, which is the pathological eye. We will see small circles with less movements on that part. On left eye swing, exaggerate response. So this is coming to the final diagnosis. This is a 46-year-old patient with a history of post-RTA, inability to abduct the right eye. Examination suggestive of 45-degree prism deviation, iso deviation with limitation of abduction. Now coming to, it is a diagnosed case of post-traumatic. So case was diagnosed with post-traumatic sixth nerve palsy. So what is the plan? Since a large angle isotropia, duction short of midline, FTT for abduction. So FDT is a must to rule out before proceeding for surgery, because why FDT is necessary? FDT, why FDT is done? In long-standing cases, there are chances of MR contracture. So to distinguish whether the esotropia is because of the LR palsy or because of the contracture due in the contraction in the medial rectus, to distinguish that, we need to do an FDT, because if FDT is tight, we have to release the medial rectus. If you don't release the medial rectus, the procedure that we are going to do is not going to be of much help, because if you contracture, the eye will be on the iso side. So in this case, we plan for a partial VRT with medial rectus recession. These are post-operative outcome. As ma'am is discussed almost everything, I will just focus on 2 slides, important slides. Then I will move on to surgical procedure. On management section of palsy, starting from occlusion, prismatic correction. In prismatic correction, given two partially recovered paresis eyes with section of palsies with less than 10-degree deviation, botulinum toxin or surgical management. And on a short basis, the pediatric cases which have isolated section of palsy, we can follow up the patient. This is not a generalized rule, but we can follow up orally, but it should be done case to case based scenario. If bilateral cases and non-isolated, we must do an MRI. Adult less than 50 year, MRI, medical evaluation, and lumbar puncture is necessary. When more than 50 year, suspecting diabetes, hypertension, other risk factors, with isolated section palsy, medical evaluation, ESR, CRP follow. If bilateral or non-isolated, MRI need to be done. This is the ma'am, as the ma'am showed this chart. This is the most important slide before moving ahead. So we need to do an FDT, whether free. If free, we can go ahead with transfusion surgery. If not free, it means FDT is try. So whatever we are going to do, we are going to do an MR recession. So if FDT is not free, in both the procedures, there will be recession. Whether to do recession and transposition or recession and resection depends on the AFGT of the lateral rectus. So I'll thank my guide, my teacher, Professor Roy sir, for teaching me about strabismus and neurophtha. Now moving to my video. My video is visible? My video is visible?
We can see it.
Yes, now it is.
Now starting from the beginning, after block, we need to check the FDT. This is how FDT is checked. We ask the patient to look towards the direction of muscle action. For example, in this, patient will ask to look towards the right side. So there will be relaxation of the medial rectus. So we want to check the contracture in the medial rectus. So we'll take the eye, we hold the eye and take away from the medial rectus in the dextroversion direction in such case, in this case. So in towards the lateral rectus side. Again, we can see that we hold at both upper and lower part and take away from the medial rectus. And we feel a tug. We feel a tightness because if MR is tight, the MR will not let go the eye freely towards the lateral rectus side. So we'll feel there is a contracture component present on this case also. So in that scenario, we need to do an MR recession. So after we have to confirm it again. So we confirm it that there is an tight FDT. So we do an MR recession. We did it in a conjunctival incision. After giving conjunctival traction suture, we give a relaxing incision and did a peritomy and tenotomy scissor used, and muscle is now hooked. After hooking muscle, a 6-0 vicryl passed through the center and it is fixed. A 6-0 vicryl fixed to the muscle. Now muscle is released from its base. After releasing, the mark is given and it is marked and muscle suture is passed. I am just forwarding because I don't want to show the recession part. I want to show the VRT part. After recession, suture is passed and fixed and MR recession was done. Now coming to the partial VRT. The full thickness VRT as in such cases always have a risk because we are operating 3 muscles, though there will be chances of anterior segment ischemia. So we did a fornix based approach. After giving fornix based incision in the fornix, we hooked the superior rectus. After hooking a superior rectus, we split the muscle in middle part and separated with the help of lens patula and muscle rope. And 2 loose ends of 6-0 vicryl from both ends have been passed. so that we will have a two ends of 60. Muscle is released from that part, and we see and freed till the back, so that it can easily be reachable towards the lateral rectus part. Now this is the lateral rectus hooked, and just near adjacent to the lateral rectus, both the ends are passed, and you can see this is superior rectus muscle. It's just adjacent to the lateral rectus part. The muscle is tight. The conjunctiva is closed. Similarly, inferior on the inferior temporal part, incision was given. Inferior rectus is hooked, and with the help of lens spatula, the conjunctiva is separated. After Jensen hook is used to completely hook the muscle. Now this is fibers peritomy C that is separated. It's needed because you need to split the muscle till so that it can easily be movable and come towards the lateral rectus part. Now muscle is split. After splitting it, now again similar to the superior rectus part, two 60 ends have been used. From both sides. So since we did a partial VRT with MR incision, the chances of anterior segment ischemia is also less, because there's still vessels left to supply to the superior rectus and inferior rectus. Vessel sparing surgery is little bit of cumbersome, and now after hooking the lateral rectus, both ends of the suture pass adjacent to it, and it is pulled and tied. So to come to this part, we need to split the muscle of superior rectus and inferior rectus to adequate size. After hooking, the muscle is tied. The conjunctiva is closed. And this is the end of the surgery and partial VRT. So this was a presentation, and
Yes. Thank you, Ashwini. That was a wonderful surgery, and I think very well recorded as well, step by step. So this will be of value to all of us. And these split VRTs are time-taking surgeries, and you just have to keep your patience when you're doing them, because you're doing multiple muscles at the same time.
And same time in between surgery, what
So
happens?
I invite any comments from Doctor. Sorry, yeah.
In between surgery also, sometimes since we are splitting the muscle, sometimes this suture 605 also slips away. So we have to hold it and suture it again. Sometimes this happens also. Because we are just suturing on the half part of the muscle, and conjunctiva got stored because we are doing three muscles. So conjunctiva also we have to keep patience and suture the conjunctiva also very well at the end of the surgery.
Absolutely, absolutely. So any comments from Dr. Paramita ma'am? When you're doing a split VRT, how do you ensure that there's no vertical disparity that comes in, or you put a faster suture? What do you normally do?
I generally prefer using a Foster suture. And one of the things I would like to highlight in Dr. Ashwini's presentation is in his 9 gauges measurements, there was a small esotropia even in the levo gaze.
Yeah, it might be spread of comitas in those cases.
So that is what spread of comitance should not be thought of as a phenomenon which occurs only with superior oblique palsies. Because I've often come across residents thinking that spread of comitance is something which is seen only in SOPs. So it is not so.
Yeah.
because the medial rectus is overacting, the contralateral lateral rectus would have a pseudo palsy kind of picture. Therefore, the spread of vomitants would result in a ESO even on the levo gauge. And another thing I wanted to highlight was that an FDT can be done both pre-operatively without the block with just topical anesthesia and can be confirmed on table when the patient cannot, of course, move the eye. And the block, I would comment on the quality of block that you have, that the pupil is beautifully dilated. And that is something that most anterior segment surgeons do not notice except for squint people. Because in our squint surgeries, we do not need the pupil to be dilated. But when the pupil is dilated on table, that means your block is going to be adequate and you are going to have sailed through the surgery without any trouble at all. So that's something I wanted to highlight.
Yes, ma'am. Especially when you have a retro position, retro light, we have to switch off the retro to have a good recording. And people is dilated. That means you have your long surgery. Patient will not be having pain, and it will give a smooth ride throughout the surgery. Or else the patient will be having pain. We have to augment with a subtenon block, and it becomes worrisome.
Right. Subhajit, Dr. Subhajit, what about you? How do you tackle your 6 nerve palsies, and what would you comment on his presentation?
So, I mean, very nicely presented video. I mean, the quality of recording and editing was very nice. I mean, we usually, the first thing that we consider in, going ahead with the planning of the surgery, I just want to add certain points. The first thing that we do is check the saccades, whether the saccades, that, because like what Swati madam had mentioned, saccades would imply a lot of things. If the saccades if we have a gradually improving 6th nerve palsy with the saccades are getting better, it's not floating and it's like a properly moving saccades, then even a recession or a resection would work, and we might not have to go ahead with the VRT itself. And so saccades, and if at all we are planning for a VRT, then we might just check the torsion once before, on a double Maddox rod torsion, because just in case there are no reported evidence of torsion, but it's safe to just, go ahead and check the torsion before going ahead with the VRT. So, once we go ahead with the VRT, nowadays most people do the single muscle thing. Just a SRT is most commonly done. So personally, I also preferred a SRT plus minus MR recession mostly, and also tried with the Nishida's procedure with a number of times. Hamelsheim, which you have done, it's obviously it's a very, it's a safety precaution against anterior segment ischemia, and it's got good results as well. So that's there. And regarding the planning of the surgery, we have to decide everything, like you said, we have to decide based on the medial rectus tightness. We have to, on table, we have to go ahead with the FDT and see whether it's tight or not. Because if the FDT is tight, then everything becomes unpredictable. So we have to counsel the patients right from the start. In case required, we might have to go ahead with a second surgery. I mean, that's very important to counsel the patient and simplify them the procedure right from the start, because a second procedure would always give a better result than a primary thing, altogether. So that's there. And I think anything else, ma'am, or sir, anything else you want to just discuss about?
Yeah, so Dr. Swati.
Yeah. I just wanted to highlight two things. As Dr. Subhajit said that, torsion, if you are planning for SRT, is much more important rather than if you want to do double VRT. Yeah, in such cases, yes, if you want to do a single muscle transposition, your transition becomes very important. But with double muscle, I don't think it would matter so much, because you are anyway, balancing each other. The second thing was, as everybody was highlighting about FDT, so it's important to check the FDT at the end of recession also. I noticed that Ashwini had done conjunctival recession as well, not just a muscle recession, but he also did conjunctival recession, which is very, very important. So you just have to look at the end of your surgery whether the muscle, where there's still tightness and you need to recess conjunctiva also. And third thing, about when you are doing transposition surgeries, I feel that's important to do a proper dissection, because you want to, free your muscle from all the attachments and then transpose it so that it comes as close as possible to the dental rectus. So that's one very, very important thing, to dissect it very properly. That's what I feel. And as Paramita was highlighting about the augmented sutures, so I think there are articles which say that if you have deviation, say less than 20 prisms or around 20 prisms, you may get away without doing augmenting sutures. So if you have, and anything, I personally follow that if you have deviations less than 30 prisms or up to 30 prisms, I don't do augmented sutures. But if, of course, if you have more than 30, you will have to go ahead.
Right. So, ma'am, when do you decide for whether you want to do a recession resection versus a transposition, and which transposition, just superior rectors or a vertical, split vertical? How do you take that decision?
See, as everybody was saying, FDT is your one key factor that you need to look at. And then, of course, SECATs, you can check qualitatively by, asking patient to fix at fingers on each side, what we normally clinically do. The other way is to look whether the eye is able to cross midline or not. If the FDT is negative, if the eye is able to cross the midline, then probably lateral rectus can generate some kind of force and you may go ahead with your procedure. But if it is not, then transposition is required. And nowadays, with SRT coming into picture and giving us such good results, I think most of us are shifting to doing SRTs unless there is pre-op hypertropia where you would like to do IRT.
Right. And of course, in terms of the sixth nerve, being one of the longest courses, we often find it as a false localizing sign in a lot of cases where there's a raised ICT, as you had mentioned. And as Ashwini mentioned, that more or less he is inclined towards MRI in a lot of the patients, on even a lumbar puncture if somebody is in that age group around 40 to 50. What is your recommendation on that? And then after you, ma'am, I'll come to Dr. Paramita. How does she investigate these? We have about 3-4 minutes.
See, it all depends on patient's age, one, risk factors, presence of risk factors. If patient is around 50 years of age and has risk factors, at a first go, probably I may not do imaging. But if patient shows no signs of improvement in another 2 to 3 weeks, I have developed a low threshold for imaging, because earlier we used to believe that you can wait for 2 months or for the palsy to improve. But I've lowered my thresholds, and if patient within 2-3 weeks does not show any sign of improvement, then I would go and do a neuroimaging. But if the patient is young and there are no signs of any other vasculopathic risk factors, straight away imaging is a choice if it's an isolated. And there's no doubt if there are associated other neurological signs and symptoms, you have to do imaging at the first go.
Right. Dr. Paramita, ma'am. Dr. Subhajit after.
It is very essential to have a low threshold for asking for neuroimaging, especially in young cases. And in fact, in today's age, it might serve us and the patients better if we have a low threshold across the ages. Okay, if you have got a clear-cut vasculopathic risk factor, then you might be somewhat safe. But otherwise, by and large, I think it is better to get a neuroimaging done when you don't have a clear-cut explanation for the sixth nerve palsy otherwise. And even in traumatic cases, if you are kind of not very clear about the mode of trauma or you do not have detailed records, it is always safer to get a neuroimaging done to save future complications, like whether like the patient's complications or any medical, like legal issues. So it is important to have a lower threshold, I feel.
Yeah, absolutely. I feel, I mean, if the patient is an affording patient, then why take a chance? I mean, if it's an obvious cause of aged patient, elderly patient with a obvious vasculopathic cause, watch. But otherwise, we might just do away with the imaging if the patient is affording, and it's easier to explain to the patient as well in that case when you're practicing.
Right. So I think that the fundus exam, of course, is very important whenever you're coming across a sixth nerve palsy. That's another thing that all of us should remember, and it's a question that's often asked in the exams and even otherwise. It is a clinical pearl that we must not forget, just to look out for papillary edema. And in particularly sometimes in cases of trauma, also you may have some forms of bleed which are going on, a subdural hematoma or something else, which may actually present with a in the lucid interval with a sixth nerve developing. So one has to be, so one has to have a look out for these things. I think that was indeed a very nice case, Ashwini, and very well managed. And I thank you. I thank Dr. Swati. I thank Dr. Subhajmita. We will obviously have some more questions coming up as and how more and more people view this on YouTube. We were live and there were a few viewers there, and about I think quite a few of us on this Zoom link as well. So on behalf of UC, I would like to thank all of you. I'd like to thank the audience. And Aarti, over to you for the next session. When do you want to announce that?
Yes. So
Thank you. It was nice interaction. Thank you.
ma'am. Thank you, ma'am.
So I would like to thank Dr. Swati, Dr. Paramita, Dr. Bhattacharya, Dr. Ashwini, and Dr. Digvijay, and our audience for an interesting session. So before we end the evening and before we end this year, let me announce the next session, which is on cataract. The session is scheduled on 31st of January 2021. And the last date of case submission or video submission is 21st of January 2021. So get ready with your cataract videos and send it across on the email address mentioned over here. So see you all in New Year. Good night and Happy New Year in advance. I just request the team for today's session to stay back. Thank you.
Thank you, sir. Thank you, Digvijay sir.
Thank you, everyone.
everybody.
Yeah.
Thank you,
Have a
everybody.
great. Bye.
Yes, we will just take a quick picture.
Yes.
And
So,
so that's the we have that as a the snapshot for the video.
Yes.
The videos are going to remain on YouTube for a long time, so we keep having lots of views.
yeah, so let me just ask, we still have some audience with us, so let me put them in waiting room. Okay, so Gunjan, you can switch on your video. So are we ready? I'm the one who is taking photo, I guess.
On your go.
Yeah, just putting people in the waiting room. Okay, ready? Thank you, everyone.
Yo, one with the yo, right?
Yeah.
Yes.
Yeah.
So I
That's
am
fine.
not coming because of this. So So let's take one more. Ready? Thank you, everyone.
Thank you,
Yeah.
thank you, ma'am. Thank you, everyone. Thank you, Subhajit.
Thank you.
Bye, sir.
Dr. Parumita.
Thank you and bye. Good night.